everyone. My name is Cédric Lonard. I'm a resident in internal medicine in Bordeaux, and I would like to present you two challenging cases we had in Bordeaux of myositis positive for anti-SSA antibodies. As we have seen this morning, the classification of myositis have changed for past years, and now is based on antibodies. In the overlap myositis, there's a place for SSA 52K antibodies, and the two cases I'm going to present to you are about that. So the first case is the case of Miss B. Miss B is 60 years old. She had a prior history of autoimmune disease with a rheumatic arthritis and an Hashimoto disease. And she was referred to us back in 2011 for muscle weakness, myalgia, and rhabdomyolysis. When we first seen her, she had on physical examination very strong weakness and myalgia of the thighs. And she had also actual muscular signs because she has difficulty to maintain her head straight. She had lumbar lordosis. The rest of the examination was normal. Notably, she had no skin lesions for dermatomyositis, no other things. And we performed a standard laboratory investigation with elevated CPK. The rest of routine blood samples was normal. The ANA was positive at 1/320 with a specificity of SSA 60 kilodalton antibodies. The rest of the antibodies, notably for myositis, was negative. She was not complaining about any dry symptoms, but we performed a salivary gland biopsy, which was normal. The EMG showed an isolated myogenic syndrome. We performed a body CT, who showed mediastinal lymph nodes, but they were not confirmed on PET scan with no fixation, and the patient did not have cardiac or pulmonary involvement of her disease. So she underwent an MRI of the spine, who showed bilateral and symmetrical muscular inflammation of the trapezius and dorsal muscles. We can see here an hyper-T2 intense signal of a muscle, which can be seen here, also here and here. And then she underwent for a suspicion of myositis and muscular biopsy, which finds irregularity of the muscle fibers with a lymphocytic infiltration. And immunohistochemistry showed class 1 HLA was marked on endothelial cells, but more interestingly on some muscle fibers very focally and not diffusely, as seen classically in polymyositis. There was no evidence for an inclusion body myositis, no vacuola, no red rag fibers. So the conclusion was it was compatible with the polymyositis, but the HLA marking was atypical and could raise concern for diagnosis of IBM, inclusion body myositis. So quickly a slide of the biopsy findings you can have in polymyositis and IBM. In polymyositis, classically you have an infiltration of T8 cells in the endomysium, who are engulfing or surrounding the non-necrotic fibers, aspect known as tunneling fibers. The IHC, as we have seen before, must be expressed diffusely and not focally in this kind of disease. In contrary, in IBM, the inflammatory infiltration is very variable. It can be important or discrete, and the typical findings are the round vacuole, the inclusion bodies, and the ragged red fibers. IHS, the class 1 HLA, is expressed focally in this kind of disease, and we can see the COX-1 activity negative fibers in this kind of disease. So we choose to treat this patient like a polymyositis despite the possibility of an IBM, and we treated her standardly by a course of steroids with methotrexate with good progression on the disease. She relapsed a few months later, so we added mensual IgIV in association with a small prednisone and methotrexate with, again, a good evolution. And a few years later, we stopped everything. We started to stop prednisone, then IgIV, and we continue with the monotherapy of methotrexate. She relapsed a few years later with a relapse confirmed on MRI, so which we said that methotrexate was inefficient to control the disease, and we switched by rituximab. with adjunction of monthly IgIV, and there was a very good response, but the patient relapsed every time we tried to space the time between the IgIV. So currently, she's under rituximab and IgIV every 6 weeks with good outcomes, but we performed MRI for the follow-up of the disease, and every time we did MRI, despite she had no clinical signs, there was still inflammatory things, very discrete, but we can see here and here. So the disease is not yet asleep. So in conclusion of this case, it's a challenging case of myositis associated with SSA antibodies very isolated, with a doubt between a polymyositis and an inclusion body myositis. Arguments for polymyositis is the symptomatology of the patient, both proximal and axial muscular weakness. The biopsy findings were typical of polymyositis, the response of the disease to immunosuppressive agents, but there were atypical signs with HLA for an IBM, and the residual inflammation on MRI, despite the immunosuppressive agents, is not very consistent with this disease. And for inclusion body myositis, the focally expressed HLA is for an argument 4. Incomplete response with immunosuppressive agents. IBM doesn't respond to immunosuppressive agents and can be worsened in some cases by it. But typically, inclusion body myositis have a very clinical presentation with proximal and distal and nervous signs which the patient didn't have. So the second case is the case of Miss S. Miss S is 64 years old. She's from Germany. She had a prior history of COPD, and she was diagnosed in 2007 in Germany of polymyositis because she had muscle weakness, swallowing disorders, rhabdomyolysis, and a muscular biopsy revealing typical polymyositis signs. She was treated in Germany by steroids, azathioprine, and when it failed, she was switched to MMF. And she was first referred in 2011 in Bordeaux. When we first seen her, she had massive weakness both in proximal and distal muscles. She had persistent swallowing disorders, rhabdomyolysis. We didn't had an history on autoimmune antibodies, so we performed a new one. And this time we had INA at 1/4000 with a specificity of SSA only. No other antibodies was found, no myositis, no DNA, no complement, low complement. Again, no dry symptoms, but and a normal biopsy, solid very gland biopsy. So we choose to treat her by course of rituximab in induction, then methotrexate for maintenance, in adjunction of prednisone steroids, and monthly IgIV because she was complaining about swallowing disorders. We had to stop methotrexate a few months later because she had a pulmonary pneumocystis. And a few months later, after we stopped methotrexate, she developed very characteristic skin lesions of dermatomyositis with photosensitivity of the head and upper trunk. And we performed a biopsy on the hands who showed an aspect when biopsy compatible with dermatomyositis of Wong. So because it was only a skin relapse and no muscular signs, we chose to treat it just by plaquenil plus IgIV and low-dose prednisone. But 2 years later, she relapsed, this time on muscular signs. She received a new pulse of rituximab, but it didn't have any effect because the MRI we performed a few months later still showed active signs of inflammation. So we couldn't get the biopsy who was done in Germany, but we were concerning about the diagnosis because it wasn't responsive to 3 immunosuppressive agents at the time. So we performed a new muscular biopsy, and this time the biopsy showed every textbook signs of IBM, and the first one has every sign of polymyositis. So we changed our diagnosis and switched to the diagnosis of inclusion body myositis. As I've said before, the treatments, the immunosuppressive agents don't work and worsen outcomes in IBM, so we choose to stop everything. But there are case reports of improvement of swallowing disorders in IBM with IgIV, so we continued it. And 3 months later, after we stopped everything, she had a flare of her disease, muscular on the skin, and a new rhabdomyolysis, so she took again prednisone, immunosuppressive agents, outcomes on skin and muscles, but she was slowly worsening for the past years, and she finally died 2 months ago from acute respiratory failure from her COPD. So in conclusion, again, a difficult, challenging case on diagnosis and treatment of myositis isolated AnriSSA antibodies, with this time doubt between a dermatomyositis and an IBM. Dermatomyositis arguments for are again axial and proximal symptomatology, the very typical skin lesions and confirmation by biopsy of dermatomyositis, the response to immunosuppressive agents. Dermatomyositis, but there were no signs on biopsy for this diagnosis. In dermatomyositis, in up to 80% of cases, there are antibodies, specific antibodies who are found were not the case here. And inclusion body myositis, she had all the signs of it on the biopsy. She had the swallowing disorders who are more prevalent in this kind of disease, up to 50% of patients. But again, the same arguments against no distal signs, no nervous signs, the partial response to immunosuppressive agents who don't go well with it. So, in conclusion, I've searched for data for the myositis associated with AnriSSA antibodies, and there's not much on PubMed. What we can see is that AnriSSA is positive in 10 to 20% of myositis, mostly in overlap myositis. It has been proven that AnriSSA's association with myositis is only for the isoform of 52 kilodalton, not 60. Despite what we found in our first patient. As we have seen this morning, AnriSSA antibodies confer a poorer outcome in dermatomyositis, notably on GO1 antibodies dermatomyositis. And there's a small clinical study of 13 patients who study only myositis associated with AnriSSA. And they found more dermatomyositis than polymyositis, less pulmonary disease, more response to prednisone. The AnriSSA was associated with a real Gougereau in only 10% of the cases, and in 10 of 13 cases in this one, there were very aspecific histological findings. So these two cases, and there's a third, but I don't have time to speak about it, were included in a study was presented at EULAR this month by Camille Oussins, who took 60 cases of myositis with AnriSSA antibodies. 50 of over the 60 myositis were biopsy proven. 43 over 60 of the AnriSSA were Gougereau syndromes. In these 60 myositis, 31 had an associated condition likely to explain the myositis, or skin lesion or dermatomyositis, or antibodies. And on the 29 remaining cases, there are 70 cases of biopsy-proven polymyositis or IBM, and the other ones were aspecific. So the question that our cases raise and this data is there a clinical unusual spectrum of myositis associated with AnriSSA, with histological patterns who are not so specific than other disease, and difficulty to treat. So thank you for your attention.